Hello, everyone, and welcome to Conversations in Interventional Cardiology. My name is Sandeep Nathan. I'm an interventional cardiologist at the University of Chicago Medicine. I also serve as an associate editor for SCAI, and it's my privilege to moderate a discussion today about a very important and comprehensive review article that was just published in SCAI titled Tricuspid Valve Regurgitation, Current Understanding and Novel Treatment Options. I'm joined today by co-authors who will be discussing this article. Presenting author will be Dr. Alessandra Sala from the Department of Cardiac Surgery, IRCCS, San Raffaele Hospital, Milan, Italy. Welcome, Alessandra.
Thank you.
And then Dr. Rebecca Hahn from the Department of Cardiology at New York Presbyterian Hospital, Columbia University Medical Center, New York, New York. Welcome, Becky.
Thank you. Thank you.
So I think we will start off with Dr. Sala presenting an overview of what's captured in this article, touching upon some of the salient points, and we'll use that as a stepping off point for some discussion about the therapies discussed. Alessandra?
Thank you. So tricuspid regurgitation is defined as the inability of the valvular leaflets to adequately coapt during ventricular systole. A new classification for TR etiology has been utilized. So primary TR accounts for a minority of cases, and it mainly refers to anatomic abnormalities that intrinsically affect the tricuspid valve or the subvalvular apparatus. Secondary or functional tricuspid regurgitation accounts for 80% of cases due to annular dilation with intact leaflets. These have been recently further subdivided into ventricular secondary TR due to mid-right ventricular dilation in the setting of left heart diseases and pulmonary hypertension or intrinsic right ventricular dysfunction, and atrial secondary tricuspid regurgitation, mainly due to right atrial dilation and annular dilation in the setting of chronic atrial fibrillation or heart failure with preserved ejection fraction. Another category has been recently inserted, which is lead-related tricuspid regurgitation, which accounts for 10 to 15% of cases. And this can be either induced by the lead itself across the tricuspid valve or simply associated to the presence of the device. Management of tricuspid regurgitation is extremely complex. In early stages of the disease, due to tricuspid regurgitation and central venous congestion, there are compensatory mechanisms that allow for adequate hemodynamic compensation and cardiac output. However, hemodynamic compensation and compensatory mechanisms in the right ventricle are limited. Therefore, with progression of the disease, there is progressive right ventricular dilation and dysfunction with the occurrence of orthopnea, dyspnea, and peripheral edema, as well as end organ involvement with hepatosplenomegaly, reduced kidney function, pleural effusions, ascites, and initial right heart failure hospitalizations. In late stages of the disease, there is severe right ventricular dilation and dysfunction with overt right heart failure and end organ damage. Therefore, the development of hepatorenal syndromes and GI disorders. Patients present with low cardiac output syndromes, with reduced capacities, and with frequent right heart failure hospitalizations. Therefore, this vicious circle should be interrupted early on in order to positively impact on the prognosis of patients. Right heart assessment is of paramount importance in these categories of patients in order to manage to stratify patients and provide the adequate treatment therapy for these patients. Non-invasive assessment of the right ventricular function is extremely complex, and it is based on an integrated evaluation of multiple parameters. Reduced both TAPSE and 3D right ventricular ejection fraction are associated with adverse outcomes. Furthermore, right ventricular function is dependent on preload and afterload. Therefore, our V2PA coupling has been identified as a powerful predictor, evaluating whether right ventricular function is adequately compensated for different loading conditions. A high TAPSE to systolic pulmonary artery pressure has been associated to a lower all-cause mortality and fewer hospitalizations for right heart failure following treatment. Moving on to invasive assessment of right heart physiology, right heart catheterization remains the gold standard, and many variables have been identified as predictors of worse outcomes, of hemodynamic worse outcomes in patients undergoing transcatheter tricuspid valve repair. And finally, cardiopulmonary testing has been proven useful in establishing severity of functional impairment, and the detection of myocardial fibrosis at cardiac magnetic resonance has demonstrated prognostic relevance in right ventricular failure. Moving on to treatment, surgical treatment is up to now the only definitive treatment for patients with severe tricuspid regurgitation. However, it is very rarely performed, mainly due to the reported high in-hospital mortality rates, as well as the poor long-term outcomes. These results, however, seem to be related to the baseline clinical characteristics of patients, as well as the stage of the disease. In fact, some recent studies have shown that patients treated in early stages of the disease, therefore before occurrence of prominent symptomatology, right ventricular dilation and dysfunction, and end organ involvement, actually experience good outcomes. The majority of patients undergo tricuspid valve repair with fewer postoperative complications, shorter both intensive care unit and postoperative length of stays. And at 5 years follow-up, they experience 100% survival and no further hospitalizations for right heart failure. However, in the current era, there are emerging and constantly increasing alternative treatment options, which are transcatheter treatment therapies. The most widely applied technique is the tricuspid transcatheter edge-to-edge repair. The results are constantly improving, and with the novel platforms, both the TriClip G4 and the Pascal devices, the procedural success has greatly increased. Results from the Triluminate pivotal study comparing tricuspid transcatheter edge-to-edge repair versus medical therapy alone have shown that tricuspid TEER is safe. It is associated with a significant reduction in tricuspid regurgitation, as well as improved symptomatology and improved quality of life. These results, an analysis of these results, together with the ongoing randomized control trials, may help in defining the appropriate patient population for treatment, as well as the expected benefits of these treatments. To overcome the limitations of transcatheter edge-to-edge repair devices, annuloplasty devices have been developed. The Cardioband system is performed in selected centers, and penetration of the procedure has been slow. However, in some studies, such as the TriRepair and the TriBand studies, they have shown that there has been a significant reduction in tricuspid regurgitation in up to 70% of cases. Also, importantly, preserving the option for further interventions. Regarding instead transcatheter valve replacement devices, there are two main options: orthotopic replacement and heterotopic replacement. There are many devices under clinical and preclinical investigation, and regarding orthotopic valve implantation, results of the TRISCEND study have shown at 1 year significant improvement in symptomatology in neofunctional class, function, and quality of life, however, with a higher rate of both bleeding and new permanent pacemaker implantation. On the other hand, heterotopic valve implantations are mainly palliative solutions in patients that remain extremely symptomatic despite optimal medical therapy. Two dedicated devices have been developed, the Tric valve and the Tricento, with successful implantations. However, long-term implications will need to be evaluated. Therefore, rapidly to conclude, when and how to treat severe tricuspid regurgitation remains a clinical dilemma. Delay in intervention until late stages of the disease results in excessive morbidity and mortality. Transcatheter therapies offer the hope of low-risk, efficacious treatments with both improvement in function and quality of life. Randomized controlled trials that are currently enrolling will determine whether mortality and right heart failure hospitalizations will also benefit from these treatments. And finally, and most importantly, heart valve centers with expertise in tricuspid valve disease are of paramount importance to define optimal treatment strategy for every patient.
Wonderful. That was a terrific overview of the paper, and brings some some graphics to everything that's described. Becky, let me just start off by asking you, how should we be thinking about following tricuspid regurgitation patients? I mean, how do we think about TR now, and how should we shift that way of thinking in terms of staging, clinical observation, testing, and so forth? I think, historically, we've just kind of, looked at the echo, shrugged, and said that looks bad, but we're not going to, send this person for a sternotomy, just for that.
Yeah, I mean, that's a great point. I think the fact that there are options out there, obviously in the United States, we don't have approved devices yet. There are 4 devices that are approved in Europe, and so there are more options, and the European guidelines reflect that and state that your workup should not delay the referral to heart valve centers that have these options available to them. And that's where I think we'll end up going as well. And because of all the attention that the tricuspid valve has gotten, I do think that we no longer are just looking at the TR and saying, oh, there's severe TR. We're now thinking about what to do and looking very hard at the clinical scenario, trying to understand what we can reverse and what we can't reverse, trying to look at predictors of progression of disease. And then also just really thinking about moving these patients forward to valve centers that have some expertise in the treatment of tricuspid regurgitation or have accessible to them transcatheter options or surgical options. And so I do think we have gradually started to move the needle toward earlier referral to centers of excellence, and also then earlier treatment. We've been really treating surgically even these patients way too late.
Yeah, I think great points all. And, these patients are certainly out there, but they're not necessarily primarily presenting to centers like ours and yours and, everyone on this call, where novel therapies are perhaps more readily available. And so it really begs the question across Europe, across the United States and beyond, how familiar should all clinicians be with the classification and staging systems that you've so beautifully detailed in tables 1 and 4 of the paper? I mean, recognition begins with, understanding, how bad is bad and when should you actually refer. I mean, every patient with TR can't be referred, obviously, and doesn't need to be referred. So, Alessandra, can you maybe talk a little bit about that? In Europe, with availability of therapies, are the majority of clinicians, cognizant of these classification systems?
Unfortunately, no. The majority of clinicians are not aware of these classifications. They are not very much aware with the great spectrum of therapies that these patients can be referred to, rather than simply medical therapy, which, as we all know, has a very limited capacity of providing benefit because it is not actually a treatment for these patients. Therefore, the biggest, the biggest difficulty for us now in Europe, even though we have these treatments, is the early or the correct referral of patients that require treatment, which can be either surgical or transcatheter, but at a certain point in their disease stage when anything that can be done is not simply palliation, because that is unfortunately when we see patients, even here in Europe, most of the times it kind of is a little bit too late for any kind of treatment. Of course, with the transcatheter treatment options, one can still try and provide some benefit for the patient. But as we have seen also in big trials and big recent trials, whenever patients have gone a little bit too far, the actual benefit of the treatment is limited, even of transcatheter treatments.
Yeah. I think, one of the other things to think about is that we're beginning to learn about other therapies, right? So we don't have enough data yet on optimization of diuretic therapy, and the acceleration of diuretics and the use of different classes of diuretics. But we've also started to learn a lot about rhythm control versus rate control in atrial fibrillation. So a couple papers now out showing that you can really significantly reduce the amount of AV valve regurgitation, so both mitral and tricuspid, by controlling the rhythm instead of just rate control in atrial fibrillation. And then finally, we're learning a lot about the pacemaker induced tricuspid regurgitation and trying to figure out an algorithm for when we should try to remove those pacemakers if they're causing the disease or leaving them alone, and then what your options are if you're going to leave a pacemaker in there. It may actually start to limit the device choice because entrapment becomes an issue for our EP colleagues.
So, I think that's a nice segue to discussing some of the therapies that are available and maybe picking between therapies depending on the mechanism of the TR and so forth. So broadly, there are 4 strategies: leaflet approximation, annuloplasty, heterotopic valve implant, and orthotopic valve implantation. And in the paper, you've described very high rates of reported success in clinical trials, and obviously not in the United States yet. Assuming that these 4 broad categories become widely available, how do you sort of think about selecting between therapies? Is it based on the mechanism of TR? Is it based on the valve complex, other considerations? Can you sort of talk a little bit about that?
Yes. So, in my opinion, the selection of the various transcatheter treatment options is greatly dependent on the mechanism of TR, because we have seen that some devices have higher procedural success in specific anatomical situations and in specific, let's say, mechanisms of tricuspid regurgitation. Therefore, I wouldn't consider, let's say, transcatheter edge-to-edge repair techniques in patients that have extremely advanced leaflet tethering, for example, or extremely dilated tricuspid annuli. At the same time, my biggest concern right now goes to transcatheter tricuspid replacement devices, because they obviously work extremely well in reducing the tricuspid regurgitation, and they have little to no obvious tricuspid regurgitation left. However, whenever treating patients that unfortunately are a little bit too late in their disease stage, this might have implications on immediate and acute right ventricular function and let's say afterload, so-called afterload mismatch. So that is my biggest concern in the selection of the various transcatheter options.
Fantastic. Becky, do you have something to add to that?
Yeah, no, I was just, wanting to agree. I mean, it was beautifully covered, the need to assess right ventricular function, because we know from both modeling of PV loops and as well as our clinical experience that the more tricuspid regurgitation you reduce, the greater at least the appearance of mechanical dysfunction of the right ventricle. And what CMR studies have shown us is that despite the fact that RV ejection fraction goes down, the forward stroke volume, you want that to go up. And so in meta-analyses and the various early feasibility trials, they've been able to show that you increase forward stroke volume. And that's really going to be the key, I think, to showing benefit for these devices. And so if we can't improve forward cardiac output, we may not be able to show hard outcomes like mortality and heart failure hospitalizations. But as the TRILUMINATE trial has shown us, we've really been able to affect quality of life. And that's been with every single device that we've ever put into the tricuspid space. We always see the patients feeling, not, I can't say always, but almost always see the patients feeling better, and being able to somewhat improve their forward flow and therefore reduce the renal and hepatic dysfunction that accompanies these very late stage patients.
And I think that's such an important point because, especially in the tricuspid space, it's it's often convenient to blame the other disease processes that are going on for the symptoms that the patients are experiencing. And so, the argument that sort of follows, or the thought process that follows, is that yes, we can fix the TR, but we can't fix all the other things that are going on. So maybe we just continue medical management and see how things go. They're certainly too sick for a sternotomy. And so we're not going to send them for a full surgical valve replacement. I think we're just about at time. Are there any other points that either of you would like to make and share with our viewers? It's a fantastic article. I encourage everyone to take a look at this and read it.
Yeah, well, I mean, I want to congratulate Alessandra, who obviously did a phenomenal job in putting it together and all the tables and attempting to, make an algorithm for device choice, which I think is still very difficult at this time. We were discussing it a little before we went live, and we're just learning so much more as the trials are ongoing, that I'm sure these algorithms will change as new devices become available, and we understand better, how to medically manage the patients as well, and to get to them a little bit earlier than we have been.
Congratulations to all the co-authors of this article. Thank you, Dr. Hahn and Dr. Sala, for joining us this evening. And we'll wrap it up right there. Thanks so much.
Thank you very much.
Thanks for having us.